Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launching of a joint NAIIMS NAMS Navigate CME program from 1st September 2023 for postgraduate students in all the NAIIMS and other eminent institutes of national importance from Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on the first Friday of every month from 3 p.m. to 5 p.m. The NAIIMS NAMS CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medical CME is to help them to be more proficient in their profession. Each session will cover 2 topics. Each topic will be of 1 hour duration, which includes 45 minutes for presentation by speaker, 15 minutes for questions and answers. Thank you for your kind support.
Hello and good afternoon everyone to the next session of NAMS-AIIMS PGIMER Navigate Medico online CME program. Last session was presented and there was a wonderful talk by the chief sir. For us, he is still the chief, Dr. O.P. Kharbanda sir. So he touched upon various aspects of dental sciences. This time it's being more specific and more detailed towards periodontal diseases, which is around the gum, which include mainly gum, and we'll know more during the session. So there's a lot of focus on local and systemic implications in health, and these are specifically related to diabetes mellitus in the aging population. And this time we have wonderful speaker from Manipal, Dr. Gopala Krishnan. So without wasting much time, I would now hand over the mic to Professor Ajay Kumar Sood sir. He is Deputy Secretary of National Academy of Medical Sciences. Over to you, sir, for the welcome address, please.
Thank you so much, Dr. Jaswant. On behalf of the National Academy of Medical Sciences, it is indeed my great privilege to welcome you all. First of all, I would like to extend warm welcome to Dr. O.P. Kharbanda sir. Sir is our senior council member and also emeritus professor. As most of you know that he has been earlier formerly the chief of the Center for Dental Education and Research in New Delhi. And the sir has kindly agreed to be the chief coordinator for this series. So we are really grateful to you, sir, and we welcome you for joining us today also. I also take this opportunity to extend warm welcome to the distinguished speaker for this afternoon, Dr. Gopal Krishnan sir. Sir is Dean and Manipal Dental College, and sir is going to talk about a very important issue, as Dr. Jaswant said, what are the local and systematic effect of periodontal disease. I am sure that the practical tips which sir is going to give to all of us will be very, very useful, especially for our PG students. So thank you so much for joining us. I also welcome all the participants from various institutions, faculty members and the PG students. And once again, I look forward for your active participation in this session. If you have any question and queries, our speaker will be happy to answer. You can kindly put your question and queries and remarks in the chat box. So once again, I welcome you all, and over to you, Dr. Jaswant, for further proceeding.
Thank you, sir. So now I request the lead for the technical team, Mr. Raviji, for a message from Professor Digambar Behera sir. Sir is the president of National Academy of Medical Sciences.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various AIIMS are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you. So now I request for a message from Professor M. Srinivas. He is the director of All India Institute of Medical Sciences, New Delhi, to the students. Thank you.
Namaskar. At the outset, I congratulate the team behind the NAMS-AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high-quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned, and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Thank you, Raviji. Am I audible now? Someone messaged he.
Yeah, sure, sir. You are audible.
Thank you. Thank you. Just I invite again Professor O.P. Kharbanda sir. He is the chief coordinator of this series, and sir is also Professor Emeritus and Council member of National Academy of Medical Sciences, and also the Director of Orthodontics and Cleft Care Center, Delhi. So over to you, sir. Without wasting much time, we would like to listen to you.
Dear friends, we have chosen a series on oral health and dental diseases to be discussed with our medical fraternity and also with our dental fraternity. Why this oral health series was chosen was to sensitize the interrelationship of oral health with systemic health, and also to make aware about what are the current trends or current concepts in rehabilitation, treatment, and prevention of the diseases. This series has been started from the first lecture, which was taken by me, and the experts have been chosen from all over India. And also we have kept the last lecture, which is about research. What are the research trends and how evidence-based dentistry and evidence-based research is coming forward to provide better treatment to the patient. In this respect, I would like to say my sincere gratitude to the National Academy of Medical Sciences for they have accepted our proposal to undertake this series. I am sure you will all be benefited, but if you have any suggestions, please feel free to give in the comment box. We are open to comments, open to suggestions, open to advice. And with this, I think I will request the next step, which is the introduction of the speaker, and which is followed by the interactive session on this topic, which is a topic which has been in discussion in decades. However, we have now definite evidence to say that how the oral health and diabetes have a bidirectional relationship, and what role a dentist can play in providing better oral health so that there is a better glycemic control, and vice versa. Over to you, sir. Thank you.
Thank you very much, sir. Now it's my turn to introduce the speaker for the day, Dr. Gopala Krishnan. Sir is the Dean and Professor of Manipal College of Dental Sciences, Manipal. Sir has been past president of Indian Society of Periodontology. He has extensive international affiliation as fellow and board member of prestigious societies, and he has also been recognized with numerous awards for his contribution to the dental health and sciences. So I now, with this just brief introduction, now I invite the speaker for the day, Dr. Gopala Krishnan, for his lecture. Over to you, sir. And we all are eager to listen to you, sir.
Thank you, sir. Can I please share my screen?
Sir, share is already installed. You just share your screen.
Yes. You able to see, sir?
Yes.
Yeah.
Visible, sir.
Good afternoon, one and all. At the outset, I would like to thank the National Academy of Medical Sciences for Dr. Digambar Behra, President of NAMS, Dr. M. Srinivas, Director AIIMS, New Delhi, and Dr. Vivek Clark, Director PGIMER, Chandigarh, and Chief Coordinator, as Dr. Jaswant had said, this he is still the chief for all of us. Dr. O.P. Karbanda, sir, thank you very much for this opportunity. And thank you, Dr. Sood and Dr. Jaswant Jagra for the wonderful introduction. So I'm here today. So as this is the institute where I come from, the Manipal College of Dental Sciences, Manipal, a constituent unit of Manipal Academy of Higher Education, Manipal. So the topic of my presentation for today is periodontal disease, local and systemic implications in health, specifically related to diabetes mellitus in the aging population. This is a topic of importance for the last several decades, and let us see how the pattern progresses and what needs to be done to get it in control. So periodontal disease, as you all know, is a chronic inflammatory disease or a condition that is characterized by dysregulated host immune responses and thereby causing microbial dysbiosis. So now if you see in the diagram, you have the symbiotic microbiota. You can see the clinical picture there, where you can see the periodontal health. The internal factors, the accessory pathogens, mainly the keystone pathogens, they play a role along with external factors and also local factors where poor oral hygiene, diet, smoking, and systemic diseases. So how does this keystone pathogen play a role? So I'll just give an overview and then we will go into the presentation. I'll break it down. So we all know that, the keystone pathogen is which has got a high impact, is the P. gingivalis organism. So what does it cost? It costs the immune subversion by producing enzymes like gingipain that interfere with the body's immune response, thereby triggering inflammation and also impairing the immune mechanism or immune response. By doing this, it starts making the condition from a symbiotic microbiota to a dysbiotic microbiota. So what happens there? So it activates and creates inflammation exudate and thereby providing nourishment for the expanded microbial community for destruction. So then with the other external factors, the tissue breakdown happens and immune response is activated, and thereby you get this periodontal disease with the combination of these factors. Now, into consideration, three main systemic diseases are being of major concern. This is the cardiovascular disease, which is the atherosclerosis and other coronary diseases, along with diabetes mellitus, with insulin resistance that we are speaking about, and adverse pregnancy outcomes, that is mainly the preterm low birth weight and preeclampsia. So this is of a major concern. So what are the factors that are involved in the orosystemic relationship? You can see the systemic inflammation occurs, the pro-inflammatory mediators, they enter the bloodstream, and with the systemic inflammation, it worsens the periodontitis. Then the bacterial dissemination happens, the production of lipopolysaccharides that cause transient bacteremia and endotoxemia. And with this, the disease progresses, and you have the altered microbiota, which we just discussed, from a symbiotic to a dysbiotic. But apart from the oral microbiota that is being dysbiotic, we also have the gut bacteria that becomes dysbiotic, thereby altering the metabolites and creating a negative impact on the systemic health. So there is an altered immune response. When that happens, we all know there's a reduced ability to fight infections and regulate inflammation. This systemic immune dysregulation worsens the periodontitis. So this is the mechanism in brief, and there are other several risk factors which are involved. So first is the lifestyle, poor oral hygiene, then the smoking and alcohol, and apart from that, high cholesterol levels. These are all the shared risk factors that trigger the disease to a much advanced condition. So the biological mechanism underlying the bidirectional relationship between periodontitis and systemic disease. So the pathogen associated molecular patterns. So this is the periodontitis affected tooth. So that binds with the host cell receptors, recruitment of inflammatory cells, and cells get, inside the inflamed tissue. Phagocytosis of the bacterial cells happen by the macrophages, apoptosis of the macrophage cells, failed resolution of inflammation, chronic systemic inflammation, and then chronic disease. So if this is controlled by, then there is a resolution of inflammation and you get back the tissue integrity. Otherwise, if it is not controlled, this goes in a cycle and worsens the condition. So this is, in general, the mechanisms that is underlying the bidirectional relationship between periodontitis and systemic disease. Now, going on to the cardiovascular disease, this systemic inflammation, it causes bacterial translocation to form atheromatous plaques. So this cardiovascular disease affects the blood flow to the gingiva and worsen the periodontal disease. So as we see in diabetes, the next condition, poor glycemic control, increased insulin resistance, and diabetes mellitus increase the risk and severity of the periodontitis. And in the adverse pregnancy outcome, because of the systemic inflammation and release of inflammatory mediators, we have preterm and low birth weight babies. So this is a statement jointly made by the European Federation of Periodontology and American Academy of Periodontology at the joint workshop held in the 2012 too, that provided this consensus report. Now, the objectives of this presentation is to understand the bidirectional relationship between diabetes and periodontitis, highlight the diagnostic and management challenges in patients with coexisting conditions, and then to review the interdisciplinary and evidence-based treatment strategies. So the major complications of diabetes, first is the cardiovascular disease, which is, characterized by heart attack and stroke. And the next one is the nerve damage, neuropathy. Then you have the kidney disease, nephropathy, eye damage, retinopathy, foot problems, that is slow healing wounds and infections. And the sixth complication of diabetes is periodontitis. So this is a statement made by the American Diabetic Association and the American Academy of Periodontology. It is a proven thing that the sixth complication of diabetes mellitus is periodontitis and periodontal disease. How the periodontal disease and diabetes interact. In case of diabetes, we all know that hyperglycemia increases the inflammation and impairs the immunity. In periodontal disease, the cytokines IL-6 and TNF-alpha, they are increased, and then that worsens the insulin resistance, which is already existing, thereby making the disease much a bizarre condition. And the common factor in between these both is the chronic inflammation that acts as a catalyst for this bidirectional relationship. So in this bidirectional relation, there is a vicious cycle where diabetes worsens the periodontitis and vice versa. So as we discussed before, we have the inflammatory response, then the symbiotic becomes the microbial dysbiosis, mean there is increased cytokine secretion, reactive oxygen species, and disruption of receptor-mediated signaling. So this periodontitis, it worsens the glycemic control, as we saw, elevates the insulin resistance via cytokine spillover, and hampers the glycemic control. Chronic hyperglycemia leads to impaired neutrophil function, delayed wound healing, and elevated pro-inflammatory cytokines, that is IL-1 and TNF-alpha. Mechanistic pathways, you have the inflammatory cytokines, IL, as we told, IL interleukin 1 beta, IL-6, TNF-alpha. They damage the tissues and they promote the insulin resistance. Now this age and rage, advanced glycation end products. These advanced glycation end products, they bind to the receptor of the advanced glycation end product, that is, it is called as RAGE receptors. Therefore, it amplifies the oxidative stress. So once there is an amplification of the oxidative stress, there is deterioration on the beta cell of pancreas and impaired insulin secretion, and thereby causing dysfunctional neutrophils, macrophages, and impaired collagen remodeling. So this is a chart that you're supposed to know, students, that how this whole mechanism occurs. Now, what are the diagnostic challenges with diabetes? Asymptomatic or subtle symptoms. This is a sign which you all need to, take into consideration. Many people, particularly with type 2 diabetes, may have no noticeable symptoms for years, thereby delaying the diagnosis. And there may be overlapping symptoms as well. Symptoms like fatigue, increased urination, and blurred vision, they can be mistaken for other conditions, delaying a diagnosis. So if these are the symptoms that you see, please do not ignore them when the patients report these symptoms. And in the adult onset type 1 diabetes, adults with type 1 diabetes may initially present with symptoms similar to type 2, making it challenging to identify the autoimmune cause. And diagnostic challenges of periodontitis. Periodontitis is a silent disease, we all know. It often develops without any symptoms, making it difficult to detect in its early stages. Patients may not seek professional care until the disease has advanced significantly, resulting in irreversible bone loss and tooth mobility. So, am I audible? Hello?
Is good.
Yes. Okay. Thank you. Because there
You
was
are audible, you are visible, we are attentive to your lecture.
No, there was a message, sir, telling it's not audible. I'm sorry about that. So coming back, thank you, sir. Coming back, patients may not seek professional care until the disease has advanced significantly, resulting in irreversible bone loss and tooth mobility when it is too late. So what are the clinical signs, students, that you need to look for? I'm going to that. Deep pockets of bone loss are often the sequelae of the past disease rather than indicators of the current active infection. So what are the signs that you're looking for? So the challenges in diagnosing the periodontal disease and diabetic patients. Diabetes is associated with more severe and extensive periodontal tissue destruction, making the diagnosis of disease more complex. Then masking by other oral conditions, patients with diabetes may experience dry mouth xerostomia, increasing caries risk, or gingival overgrowth from calcium channel blockers, which can mask the signs of periodontitis. Then hyperglycemia impairs the neutrophil function, reducing the body's ability to fight the bacterial infections and increasing susceptibility to the severe periodontal disease. Now you have to see there are overlapping risk factors. The bidirectional relationship between diabetes and periodontitis with each condition influencing the other's development complicates the identification of the primary issue. It's very important to note that. To overcome this these all challenges, a comprehensive approach is needed. So how do you get this comprehensive approach? Glycemic control assessment, we have the chairside HbA1c testing that can help identify patients with elevated blood glucose, indicating higher risk for periodontitis. Then, very, very important as a periodontist, thorough clinical examination. Periodontist must conduct a detailed periodontal examination looking for signs not only like plaque, bleeding on probing or pocket depth, and gingival index assessment, but also multiple periodontal abscess. So once you get these kind of signs and symptoms, you refer for the diabetes screening. So periodontal examination findings such as advanced clinical attachment loss, multiple periodontal abscess can serve as an indicator for undiagnosed diabetes or pre-diabetes, prompting referral for medical screening. Comprehensive protocol, a meticulous approach is essential for accurate diagnosis and risk stratification. A very, very careful history taking is important. A detailed medical and dental history, including the family history of diabetes and periodontitis, is a must. Then you should also look at the medication review and lifestyle factors like diet, exercise, and stress. Now going to the clinical and lab markers, full mouth periodontal charting with a 6-point probing depths, clinical attachment loss and bleeding on probing should be recorded, HbA1c, fasting glucose, and C-reactive protein levels. And going to the risk factor analysis, you should see the other factors, assessment of the smoking status, obesity, psychological stress, and also if he's an alcoholic, take the history about the frequency. Then genetic predispositions and socioeconomic determinants of health. Interdisciplinary evaluation, this is very important. Unless there is a proper communication, collaboration, we will not be able to, treat the condition very effectively. So as I said, effective management necessitates seamless communication and referral between the medical and dental professionals. When to refer? Refer the patients with uncontrolled diabetes to an endocrinologist and those with significant periodontal breakdown to a periodontist. Collaborative diagnostic workup, joint interpretation of clinical findings, laboratory results, and imaging for a holistic patient profile. Shared patient education, educate the patients on the bidirectional link and the importance of integrated self-care practices. So effective, videos showing the risk of the bidirectional link between the systemic disease and perio should be playing in your offices in the patient waiting area. They get educated and then you do personal counseling and motivate them so that they are aware, so that the proper self-care is taken by the patients. Now the collaborative care, who are all important? Periodontists, endocrinologists, and nutritionists for the proper diet. And more than all these things, there should be a collaborative approach together with the patient. Once this is achieved, a very successful control of the condition could be achieved and also reversed in cases which I'm going to tell later in my presentation. So this is the screening for the diabetes, type 2 diabetes and periodontitis patients. So primary care and dental clinic, you assess the periodontitis, screen for diabetes mellitus history, fasting capillary glucose, normal, it's fine, abnormal, then you refer them to the medical professional, and then you have a joint assessment of the condition and joint management of the same. Now I'm going to tell with this, there's a case study, a patient of 55-year-old male with type 2 diabetes with severe periodontitis, HbA1c of 7.5 presented. This was in my previous institution. So challenges is poor glycemic control, poor oral hygiene, management, So before going to that, I would like to tell you all, this patient, when they presented, they did not know that they had diabetes. You can see the multiple abscess over here, periodontal abscess. That is the first red flag and a red signal. When you have this multiple periodontitis, you please ask the patient to go get their refer to a physician and recommend to get their HbA1c status checked. And when it was checked, it was 7.5. And this I have seen in my almost 23 years of my experience, that many patients, they go undiagnosed, and this is a very important classic finding, multiple periodontal abscess, where patients do not know, and when they are checked, 99% of them are diagnosed with type 2 diabetes mellitus. Management now. So they also have poor oral hygiene. You know, there's a saying, which caused the condition? Is it the egg, hen, or the, chicken or the egg which came first? It is both symbiotic. So one condition complements the other condition and makes the condition more enlarged and bizarre. So SRP, antibiotics, diabetes management. So outcome is reduced probing prep. HbA1c was reduced to 6 after 6 months. And then later it was brought down to almost 5.8, and it was in a very good control. Standard periodontal therapy, scaling and root planing. This is the gold standard, is non-surgical periodontal therapy wherever to avoid, invasive approach that could be avoided. So thereby it reduces the microbial load and inflammation, oral hygiene instructions, patient education and motivation, use of interdental aids and antimicrobial rinses. Now, this is an article that is a message that I had published in the Journal of Indian Society of Periodontology in 2024 when I was the president of the society. Interdental cleansing. It is a neglected side dish in oral hygiene maintenance. It's simple, but yet important. People neglect this. They just feel that brushing the teeth and proper brushing of the teeth, that should be, educated to the patient. And also supportively, they have to do this interdental cleansing, which is definitely a neglected side dish in oral hygiene maintenance. Almost, I would say almost about 60 to 70% of the population. Another important thing, another article, my president's message was published, which I wrote. Scaling, root planing, toothbrushing, interdental cleansing. But is the oral hygiene complete without the tongue cleaning? People forget about the tongue cleaning. So they feel that if I have done the cleaning of the oral cavity and also interdental, I'm done. But then there is another area where that could harbor the bacteria. So it is not complete till the tongue cleaning is done, followed by the brushing, interdental cleansing, and the tongue cleaning. Then you go for the antimicrobial rinses. Then only the whole regimen is complete and the work is done 100%. So have a look at this also, what I have suggested this, and you can make this as a part of your counseling advice when you counsel the patients for better oral hygiene. Adjunctive therapies, enhancing the treatment outcomes. So beyond the standard care, several therapies can augment treatment effectiveness, especially in complex cases. So you have the local drug delivery and the systemic agents. So when we go in the minimally invasive approach, you go to the site-specific antimicrobials like chlorhexidine chips. Systemic can come later if required, doxycycline. Then you have metronidazole gel. Then you have ornidazole gel. Then you have tetracycline fibers. Then for host modulation, low dose doxycycline can inhibit the destructive host enzyme, the MMPs, reducing the inflammation without the antimicrobial effects. And another important thing, nutrition, anti-inflammatory diets. Encouraging diets rich in antioxidants and omega-3 fatty acids can reduce systemic inflammation, benefiting both periodontal and glycemic control. Now, diabetes management to support periodontal healing. So, a good glycemic control with insulin or anti-diabetic therapy or oral hypoglycemic agents and lifestyle changes, monitoring HbA1c on a regular time frame, and with low sugar anti-inflammatory diets, you have a good collaborative care and the outcome is improved. Nutritional support and anti-inflammatory diets rich in omega-3 fatty acids, antioxidants, vitamin C and vitamin E, which are rich, that should be prescribed to the patient in consultation with the medical physician. Anti-inflammatory diet reduces systemic inflammation and also it causes periodontal disease breakdown. Now, what are the therapies for the periodontitis and diabetes? So we are going to look at that. So you have the lasers, which you can, apart from the oral guys, you have the lasers if it's you want to have a minimal invasive approach. What are the challenges in managing both the conditions? Bidirectional relationship, increased inflammation, impaired healing, worsened glycemic control, dental complications. Standard management strategies, you have the integrated healthcare, good oral hygiene, stable blood sugar, and prompt treatment. Emerging research and innovations in management. In periodontitis management, you have the host modulation therapies like low-dose doxycycline, advanced periodontal treatment, just as I said, as you see, lasers, and nanotechnology for regeneration such as bioactive glass and titanium nanotube coated dental implants. Then you have the systemic antibiotics combined with mechanical therapy. And for the diabetes management, you have novel drug classes such as dipeptidyl peptidase, DPP4 inhibitors, advanced insulin delivery such as development of patch pumps, and peptide-based therapies like glucose-dependent insulinotropic polypeptide GIP and glucagon-like peptide. And you have more now in the commercial thing which has been there for the last couple of years, but then more research is required to prove the condition. This is, I would like you all to have a look. Diabetes management, these are the two articles. One is published in the International Journal of Diabetes and Endocrinology. Effectiveness of specifically modified plant-based dietary intervention and anti-gravity exercise in type 2 diabetics, a follow-up study. This was published in the following journal by Dr. Pramod Tripathi and Dr. Arjun Lal Kakrani. And this is a natural therapy. There is, what is this plant-based diet? So it is just a veg smoothie. It's a natural therapy, and this has proven successful. Over 15 to 20,000 people have been reversed of their diabetics. People who are on the insulin and on the oral hypoglycemic, they have, they have stopped them. It is just if you want the details of this, it is usually, it's a mixture of a vegetable, half cup of bottle gourd, 2 minor greens, that is, and plus low glycemic index fruit, plus black pepper. So it's all blended with water, and it's a smoothie, having one in the morning and one in the evening. Apart from that, there are specific exercises, of course, with diet regulations and specific anti-gravity exercises, just done meticulously. It was brought down. I can say with my own personal example, I was a diabetic with 6.7, close to 7 at one point, the HbA1c. With this, it has been effective, and I could get it down to 5.7. So you can see this. Again, I had published this along with Dr. Tripathi and our colleagues, a natural plant-based diet and anti-gravity exercise, an effective way of controlling type 2 diabetes mellitus. So for more information, you can feel free to reach out, and I'll be happy to give you my experience. So evidence-based outcomes. So there was an article that is published by the International Diabetes Federation and European Federation of Periodontology, Scientific Evidence on the Links Between Periodontal Disease and Diabetes. This is a consensus report. So it is published in the Journal of Clinical Periodontology in the year 2017. I request you to go through this. And in the Indian Society of Periodontology, we had a joint statement along with the Research Society for the Study of Diabetes in India, Management of Periodontal Disease in Patients with Diabetes. It is a good clinical practice guidelines that was published in the Journal of Indian Society of Periodontology. So requesting you to read these guidelines for effective control and also counseling to the patient. There's another article, systematic meta-analysis and systematic review in the Journal of Applied Oral Science, effect of periodontal treatment in patients with periodontitis and diabetes. And you also have research reports, clinical, which is being published on long-term effect of periodontal therapy on HbA1c changes in type 2 diabetes. So to conclude, there is definitely a bidirectional link. So diabetes and periodontal disease mutually influence each other's progression and outcomes. Diagnostic challenges. So you have to have an integration of clinical, biochemical, and imaging tools that is essential for early detection. Management strategies, as we discussed, personalized treatment plans, dentist, physician, and nutritionist collaboration, adjunctive therapies like laser, host modulation, local drug delivery, etc. The key takeaway is the approach should be a holistic, patient-centered approach, and control of one condition improves the other. And this is very, very, very important in having a successful management. So managing diabetes and periodontal disease together ensures better overall health outcomes. So this is the references of my presentation, and I thank you all, and I thank the NAMS India for giving me this opportunity to share my thoughts on this very important topic. And I thank you all very much for your kind attention. You can feel free to reach me on my email or on my other social media links. Thank you very much.
Thank you very much, sir, for the wonderful lecture, wonderful talk, I would say. And the presentation indeed, like that was very interactive and very engaging, including all the pictures and then scientific papers and everything. So thank you, sir.
Thank you, sir.
Now I request first Professor O.P. Kharbanda, sir, for his expert comment and his remarks about the topic, and if he want to add something for this topic. Sir, over to you, sir.
Why we chose this topic was that because many patients who are coming to dentist for the periodontal problem, the dentist looks at it as a local problem. Although this local problem in the mouth has been aggravated by systemic condition of diabetic mellitus. And the patients are not aware about it. Many people are not aware about their condition. So here the responsibility of a dental surgeon becomes a little bit more, if it is, he thinks it more ethically and more morally, to suspect a patient with pus discharging pockets or unusual breakdown of periodontal ligament or teeth mobility, to have it investigated with the endocrinologist. And it is, as Dr. Saab has mentioned already, that he has presented one case also that he suspected and it came out to be true. So that is one aspect of it. The second aspect of the periodontal treatment, which a dentist's responsibility involved, that those patients who are diagnosed as diabetic mellitus, but their oral health is not controlled. Their periodontal health is not optimized. So now, what is their duty? Their duty is to convince the patient, motivate the patient, and use extra measures to maintain oral hygiene, which may include water jet, it may include interdental brush, it may include an electrical brush. So essentially, the dental surgeon has to educate any patient with diabetic mellitus to maintain optimized oral hygiene, which will require extra effort. And all those chronic abscesses should be treated with antibiotic or suitable therapy. Now, why this is important? This is important because the periodontal tissues do not have healing of regeneration. The dental tissues don't have healing of regeneration. So once the alveolar bone is lost in a patient with diabetic mellitus, with periodontal breakdown, even putting an implant or putting a denture has become very difficult. It is not impossible, but it requires much more technique-sensitive methods and more costly, expensive methods to rehabilitate the mouth. So therefore, it is become pertinent that the oral hygiene measures, once they are implemented in totality, they are also expected to provide a better glycemic control to the patients with diabetic mellitus. So you are benefiting both ways. You are getting a better control on glycemic control, and also you are preserving the tissues of the oral cavity, which would have been otherwise lost with periodontal breakdown. That is one aspect of it. The second aspect of why we chose this topic was that very often the dental personnel are not fully aware about the implication, and vis-a-vis medical people are not aware about the implications of periodontal breakdown with diabetes. So therefore, this topic was carefully chosen because many of the participants of our CME would be medical postgraduates from different specialties, and it becomes our duty as a dental surgeons to make them aware about what we can do for them, which will help the patient to have a better quality of life. In fact, the entire series has been planned in such a way. We have chosen those topics which would educate both. It will have a bi-directional relationship, beneficial relationship between medical personnel and dental personnel. I can see there are a lot of questions which has come up, particularly with related to low birth weight with periodontal disease. Maybe Dr. Saab will like to answer that. And there is also there are also some more questions actually. If something from Punjab and also from Dr. Rajat Mitra, if you like to answer that.
Yes. Thank you, sir. Yes. The next thing which is being established is with the preterm low birth weight in the mothers. It is studies which has been done abroad and successfully published from India also. Yes, this is one thing where we will. Our as an Indian Society of Periodontology, long back, maybe about 10 years back, there was a dental health card which is being circulated for these checkups to the government hospital, which has been recommended by the Dental Council of India to all the hospitals in the government sector. So yes, but then I do agree that we would be coming with specific guidelines with related to the preterm low birth weight for more, percolation amongst this information amongst the rural population, where people, the awareness not only in the urban but also in the rural population is very important to have a control on this. Yes, that is another aspect. That is one question. And then that's Colonel Dr. Rajat Mitra. And us, we have to also sensitize the gynecologists with relation to the when they should be, when the treatment at which trimester and how to manage the. Again, it is a team approach, and that is one question which is there. And another one.
These are the two questions here.
Yeah, these are the two questions. Anyone else, you have any other question, you can feel free to.
I would request the participants to certainly make comments and advise also. And I hope they know about the next lecture, which is on 6th of Feb. And the topic on 6th of Feb is about pediatric dentistry, prevention of dental caries and dental trauma.
Yes, sir. So this is the, I would like to say that as I shared my email, please feel free to email me the questions. I'll be able to answer this. I think one more question which has come.
Yeah, sir. So Dr. Anjali, she asked that the tooth caries. So if we need to remove decayed tooth, so which is the ideal trimester for the pregnancy?
We usually try to avoid it neither in the first or in the third. It's in the second, and that too we try to do at most. If it is most, if it is unbearable, we try to go conservatively, and then we take a call and consensus with the physician, that's the gynecologist. As long as possible, we try to avoid that. Again, that's what as a thing. This is another thing where the guidelines we will be making and then sharing with it. Yes, it is in the second trimester, and that too with consensus of the medical specialist, the gynecologist.
Right, sir. Sir, this second question I found this on YouTube for this particular ongoing live session. Yes, sir. So Dr. Supreet, he asked that, sir, there in Punjab, after a child eat pinni ka laddu, so
Okay.
elderly people, they often advise them to take a pinch of salt before going out to play. So, and they relate it to the ghost, and this is a common cultural practice in northern India, including Rajasthan, some parts of UP also, some parts of MP. So after that, some relate it maybe that after taking pinch of salt, the bacterial growth is maybe halted to some extent. Like with sugar, bacteria may grow, but after taking salt, they may halt. I don't know. So he just asked, is it a good practice to continue for better oral health?
See, after taking a sweet and then having a salt, pinch of salt, I wouldn't, there's nothing scientifically proven, but yes, in those days, salt water, saline gargle is always good, but not eating salt directly after this, nothing to prove that. But yes, saline water gargle has always proved very, very effective in, in the, what do you mean to say, in at least not arresting the condition, but then
reducing the inflammation.
a lot of information. Yes, yes. Yes, sir. I'm sorry, Dr. OP, sir.
People do gargle to reduce inflammation. Yeah.
Yes, they do that, but not pinch of salt eating after a sweet. It's something new. Yes.
Maybe it changes the pH from minus to neutral.
Yes.
Maybe we don't know.
Yes, sir.
Yeah, maybe it needs to be researched.
Yes, there's no
Some of the
scientific
traditional
evidence.
practices need to be researched. Actually.
Yes, it's a village tradition. It must be, but it's something new. I got to learn something from this question. Yes.
Okay, sir. So I request the participants, if anyone wants to ask anything, they can just unmute or they can just raise their hand. We can unmute them and then they can ask. There is another question in the chat box, sir. So this is the question to Kharbanda, sir. So what is the ideal attachment of periodontium to start an orthodontic treatment? Or to which level attachment of periodontium should we start orthodontic treatment?
This is a very good question. Normally, we expect that all orthodontic treatments are usually done before adulthood. So, but at that age, the periodontal attachments are normal, which is on the cementum and some part is on the cervico-enamel junction. We never start orthodontic treatment till periodontal health is optimized.
Yes.
That is the first thing. So this is the protocol we followed in AIIMS over the years. Any patient who is coming to us, the first step is to make his oral health optimized, not just periodontal health. He should be free from dental caries. He should be free from periodontal disease, from gingivitis, and he should be motivated enough to maintain that with the orthodontic appliance in mouth, which demand much more effort to keep the mouth clean. So these things are very, very critical. So patient's motivation to keep the oral health optimized is prerequisite before starting orthodontic treatment. Now, coming to that specific level of attachment, now we understand that as the periodontal breakdown occurs, the center of rotation of the tooth changes. And it goes more apically. So therefore, in any given situation, if the periodontal breakdown is, or the root length is more than 50% or less than 50%, I would say, we usually don't initiate orthodontic treatment because that will lead to breakdown of the remaining periodontal ligament. So that is the principle we follow. And with many more adult patients coming for orthodontic treatment now than before, because of the quality of life, those who could not get their treatment because of the not availability of experts or not being aware, and now they are in good jobs, they are in a profession where their profession demands optimized oral health. So we like to use very, very advanced appliances which deliver very small forces, and we have a better control. So therefore, we mostly like to use copper nitride or nickel titanium wires at a low force delivery. And of course, it is a prerequisite that sometimes even we do splinting before we start periodontal treatment. So in such patients, the periodontal treatment and orthodontic treatment becomes an kind of a interdisciplinary treatment where the periodontist and the orthodontist work together. And in fact, in some situations, orthodontic intrusion can regenerate the bone. That is, there are also situations where if there are proclination and there is a loss of periodontal tissue, when the teeth are placed in the normal position and intruded, we couldn't get the root length. So this is a very complex science, not easy to explain in this lecture, but however, that is the gist I have given.
Yes, that is the gold standard of care, what Dr. Karbanda sir has said. So unless it is healthy, they do not do, because it will further accelerate the breakdown. So ideal optimal health. There's a question from Dr. Kumar Anand. Yes, doctor, you can unmute yourself.
So this question was asked by him only. Like he just
Okay.
put this question in the chat box. So
Okay.
if you still want to ask anything, you can also unmute yourself, Dr. Anand.
One thing more I
Hello.
wish to add. Kumar, yes, please. Yes, Kumar.
Sir, very good afternoon, sir.
Very good afternoon. You are calling from
Good
which
afternoon
place?
to all the respected teachers, sir.
कहाँ से बोल रहे हैं आप?
सर मैं किशनगंज बिहार से बोल रहा हूँ and
बिहार
I'm
से.
a resident of Patna, but I'm currently serving as an assistant professor in Mata Gujari Memorial Medical College, sir.
Okay.
The same question, sir, which I put up to you, sir, because, sir, many of the cases in this region, what I have come across, sir, that in my case only, sir, recently, a few months back, I have started a patient for an orthodontic treatment in which her periodontium condition was good and attachment was more than 75%, sir. And after starting the treatment, sir, the periodontium, I think what happened is, I think the molars and the first premolars, they got in grade 1 mobility, sir. Even though I got an X-ray IUPA, the periodontal attachment is still the 75%. But some way or the other, I'm not able to get that thing. How did it got, means, how did it get to a grade 1 mobility, sir? So that was the main question. And
So I will explain you that in our experience in such cases, what we do, we
Yes.
ensure that plaque score is 0, which is not easy to make it 0. So you
Okay,
need to
sir.
have a disclosing agent
Yes, sir.
given to the patient, shown in the mirror that how to make plaque score 0. Now, in spite of the best effort, patient won't be able to make it 0. So I used to call these patients because I had many adult patients at 50 years, 45 years, even 60 years. I used to call the patient in my office and I used to brush in the patient's mouth myself to make it 0. The moment you make plaque score 0 and put him in on doxycycline on long term, you can put. Doctor, I should not be giving this prescription while when a periodontist is here. He should be giving you this prescription.
Yes.
So I used to
Yes.
put the patients on doxycycline long term,
Okay,
100
sir.
milligram per day,
Yes.
make
Okay.
plaque score 0, and local metronidazole applications. Make it sure that
Okay.
there is no furcation will come the moment there is a furcation involvement. So it
Involvement,
also
correct.
depends upon the type of bone loss. It is a vertical or it is horizontal, or it is a kind of a complex bone loss. So the intraoral peripheral X-ray is only a 2D picture.
Yes, sir.
But you need to evaluate that patient on all sides of the pocket, including percussion of the roots. That will give you the right picture. But don't worry, if their mobility, the moment you make the plaque score 0, the moment you fix the everything else, mobility will come down. Only thing is, you should have a compromise. You should be willing to close the case at compromise results. You may not achieve the ideal tooth movement. And rest of the movements you can achieve with aligners, if you like.
Okay.
Aligners
Clean.
are very, very supportive in adult orthodontics.
Okay, sir.
Yeah.
Yes, sir.
Yeah. I hope it
Thank
helps
you,
your
sir.
patient. Yeah.
Thank you, sir.
Any comment from the periodontist is welcome.
No, you
Dr.
said it all,
Gopal.
sir. You
Dr.
said it all,
Gopal
sir.
is welcome.
No, you said it all. You said it
I
all.
said it.
That is the thing, doctor. You'll have to, meticulously follow.
Okay, sir. I have given medication for a month, including metronidazole, doxycycline. The condition has been improved, but
नहीं,
this
आपको
is the
उसके मुंह
first
में ब्रश
time.
करना पड़ेगा आपको.
Okay, sir.
आपको, you have to call the patient every week in such patients in your office, and you have to yourself make these plaque score 0 in the mouth.
Okay, sir. Okay, sir.
It is a hard job, but there is no choice.
Ensure he's doing the right oral hygiene practice. That is very important.
No, of course, once you start doing that, patient will learn how meticulously you are doing, then patient will start following you.
Yes. Yeah.
Because the patient's motivation goes with doctor's motivation.
Correct. Correct.
When they say that doctor is so sincere and so committed in my mouth, then he should also feel that I should be somewhat committed to do for myself. Yeah.
Yes. Definitely, sir. Definitely.
Thank you, sir. Thank you.
Thank you.
If anyone else,
I like to add few more comments here,
Please,
since
sir,
there
please.
is some time.
please.
I wish to let my audience know that periodontal disease is taken very lightly, but this is one of the most difficult diseases to manage because the damage which occurs is irreversible. Once the gingival attachment is lost, to reattach the gingiva, and it's a very, very delicate attachment. The gum is very delicately attached to the tooth surface, and when there is a microbial invasion from the pocket, it is not possible to stop. Now, those doctors who are practicing for long, maybe dental surgeons or even practitioners, who have faced this dilemma of patients who are coming to you for full dentures at the age of 70, they are malnourished, they become depressed, they become psychologically disturbed, they develop obstructive sleep apnea, their tongues falls back, and whatnot and whatnot. And therefore, the preservation of periodontal tissue and dental hard tissue is a life course approach. In
Yes.
all other diseases, it's a one time or twice. You have tuberculosis, you take a course of medication, you are rid of tuberculosis. You have polio, you get vaccination, you don't get polio. But that is not the case with oral cavity. Oral cavity requires a continuous effort throughout life to maintain the teeth in good health. And this is the message which we want to give, that to maintain good health is simple, maintaining the oral hygiene. But most of the people don't know how to maintain oral hygiene. Therefore, maybe we have kept one particular session in this series, that how to use oral hygiene devices in the mouth, how to use them. So one session will be devoted only on this. What are different devices? Which devices elderly should use? Which child should use? Which persons with healthy mouth should use? Which with unhealthy mouth should use? And how effectively to use them? There is a special session on this.
Yes.
So my humble request to the participants that they should encourage their colleagues and also the students to participate. And I must compliment Ramaiya University that on my request, they have created a classroom setting where all the postgraduates and undergraduates are listening to Dr. Gopal Krishnan. So
Thank
they
you.
have optimized. Yes.
Thank you, sir. One thing I would like to add again, I re-emphasize, like after what Dr. Karbanda sir has said, as I said, oral hygiene is not complete with just brushing and flossing. Tongue cleaning, the devices play a role, but to use these. I mean, it is complete only when you do the tongue cleaning as well, because that is the one which is being neglected in most parts of the world. And there are now, like Dr. Karbanda sir even said, that for each of these conditions, they have good, devices, even for tongue cleaning, because there are the people would say that, gagging reflex happens, but then there are very good devices that, help, in cleaning the tongue without having the gagging effect. So it is not, this is when you do the counseling for the patients, all of you, this 3 is must and important: right way of brushing, right way of flossing, and right way of tongue cleaning. Thank you.
Thank you, sir. Thank you for the interactive discussion that held post presentation. So, if still we have time, and if anyone wants to ask, they can just raise their hand, or they can just write. I'm just checking the participant list. If anyone has raised their hand, no. Okay. So I think they can still mail, sir. Sir has provided his email address, so you are free to mail, sir. And you can also contact us if you haven't seen his email address. We will provide you email address of sir. So I think now it's time for the vote of thanks. So now I request Professor Ajay Kumar Sood, sir, the Deputy Secretary of National Academy of Medical Sciences, for the vote of thanks. Over to you, sir.
Thank you, Dr. Jaswant. Once again, it is my great pleasure to thank the distinguished speaker for this session, Dr. Gopal Krishnan, sir, for being with us and covering this topic very comprehensively. And as Dr. Karbanda said, it has benefited not only the dental student, but also the medical students as well. And we look forward for a blessing in future also. Thank you so much, sir.
Yes.
I also thank the chief coordinator for this series, Dr. O.P. Karbanda, sir, for being with us. He has selected the best topics and also the best resource person. So we are always grateful to you, sir. Despite your very busy schedule, you are able to be with us, and we look for your support and blessing in future also. I would like to thank all the participants, our faculty members and the PG students who have joined us. And once again, I would like to say it is your own program. As our chief coordinator sir said that if you have any suggestion, you can please write to us. We'll try to improve it. And also you can come forward to give your suggestion on the topics which we need to cover in future also. For the information of the participant that we have a ICMR NAMS biostatistical helpline. So those MDS students who are doing their thesis and they find it difficult, they can sort of make use of this facility. It is free and you can always book a slot. And the experts from National Academy and ICMR will be happy to help you for your thesis work. And also for the young faculty members, if you want to use this. Another information is that we have, in collaboration with IIIT Hyderabad, online 12 weeks course on artificial intelligence in healthcare. So if you want to join that, currently the third batch is going on, but the registration for the next batch is going to open very soon, and we have circulated with a brochure. Again, for this dental series, then all the topics which we are planning to cover, we have made a brochure, and this brochure we have again sent to you on the chat box, and we will also circulate again to all the dental colleges for your information. Once again, I will like to thank and request all the faculty members, especially dental faculty members. NAMS have fellowships and membership programs. The details are on the NAMS website. And in case you want to hold a CME program or a PG student and other faculty members, NAMS will be happy to sponsor that CME program. And all the details are available on NAMS website. You can apply and NAMS will be happy to support you. I would like to thank once again Dr. Jaswant for being with us and coordinating this and moderating this session so well. You have been great support to the Academy right from the very beginning. Here in the NAMS, we have IT team headed by Mr. Ravi and of course Mr. Shivam. They have been writing you again and again, reminding you and sending you all the details. And they are also ensuring that these recordings are available on NAMS website. And also we have circulated the details of the link of the video recording which we have on the website. So I would like to thank Dr. Kavita Prasad. She is Dean of the Ramaiah, yes, I now remember her. So Madam, thank you so much for organizing this session and the student, especially PG student, as well as undergraduate student, they were able to take benefit of this very interesting talk from Dr. Gopalakrishnan sir. So once again, I like to thank all of you for being with us and making this session very, very interesting by asking questions and giving your comment. Thank you so much. Over to you, Dr. Jaswant.
Thank you.
Thank you, sir. So I think with your permission, we can mark the closure of the session.
Thank you, sir. Thank you, everyone. Yes.
Thank you, Dr. Gopal. Thank you, Dr. Daswant. Thank you,
Thank
Dr.
you, sir.
Soos, everyone.
Thank you, sir.